My name is Alexandria Murphy, and I am the Child Development System Integration Specialist for Children and Youth with Special Healthcare Needs section at the Colorado Department of Public Health and Environment. JFK Partners and the Colorado Title V MCH program collaboratively present a quarterly educational series to address the current Colorado Title V MCH priorities and emerging issues. This series is intended to expand the capacity of the maternal child health, or MCH, workforce and related systems to better serve infants, children, youth, including those with special healthcare needs, and their families. We are expecting about 90 people to join us, either at the live site or online. Feel free to type questions or comments in the chat box at any time. Please be sure to mute your microphones so we don't hear background noise. We are recording today's event and will archive it on the JFK Partners website, along with the other webinars in this series. We have already posted the handout for today on this page, so you are welcome to print or save for future reference. Following the webinar, you will receive a link requesting an evaluation. You may also request a certificate of attendance in the evaluation. Today's topic is improving access to developmental evaluations in Colorado. Our speakers include Michele Ebendick from ABCD Colorado, Assuring Better Child Health and Development, Sandra Friedman, MD, MPH from Developmental Pediatrics and JFK Partners, and I will now turn it over to my colleague, Angie Goodger from the Children and Youth with Special Healthcare Needs program at CDPHE.
Great, thanks, Alex. So today's objectives really are around understanding the importance of developmental screening and referrals to early intervention, known as Part C, but also to schools for screening and assessment of children older than 3 years of age, which is Part B. We want to talk about some of the barriers to receiving a diagnosis, so that medical piece component around ASD and DD, as well as examples of strategies for improving access to diagnostic developmental evaluations. If we have time, we want to hear more from the group around opportunities to improve the referral system. So I have a few slides. As Alex mentioned, my name is Angie Goodger. I'm our Pediatric Care Coordination Systems Consultant. And our section has historically worked with JFK Partners to identify, develop, and plan several webinars a year. I'm not sure if Alex said it, but we are funded by Title V through the Maternal and Child Health Bureau. Yeah, so that's where we're funded from. But what I wanted to share with you is just a little bit about our section and try to actually set the stage for why we're having this conversation today and why we're talking about referrals for developmental evaluation. You might wonder what the work in our section is responsible for. And so really, this is actually our strategic plan, part of it. And so we really work to identify and implement policy and systems changes that support communication and collaboration between programs that are providing care coordination for children and youth. We try to enhance statewide access to pediatric specialty care, including behavioral health, expand access to information and resources for women of reproductive age, youth, children, including children and youth with special health care needs and their families, and also to improve developmental screening, referral, and intervention services. If you've known our section for any length of time, you might notice that we only recently moved the developmental screening work into our section. It was part of our branch, but we've really been intentional around including that in our work for children and youth with special health care needs. And also, we've really worked to switch from services, so that one-on-one work, to more of a systems level. And then the other thing that we've really worked on is to make sure that our budget reflects that shift. So are we putting money where we say we're trying to work, right? Great. So again, that services to a systems approach is really looking at a population health approach. About 10 years ago, the Maternal Child Health Bureau actually started making that shift. And so we've really worked to try to also increase our focus looking at population health systems and approaches in order to really maximize those health outcomes for both women of reproductive age, but also children and youth with special health care needs. And it's also important to think about how do we do that within our ever-changing landscape, right? We have increased care coordination in our state that's associated with case management, our regional accountable entities through our accountable care collaborative, and also behavioral health integration. There's just a lot of folks that are working on care coordination and case management. We feel that we have a role in public health to both that our role in public health for serving children and youth with special health care needs is twofold. One, to ensure that they have access to the needed supports and services, including coordinated care and specialty care, but also strengthening the healthcare system to deliver other needed services and supports. And so as we do that, and we know that things have been strengthened, these are the questions that we've been asking. And of course, then we have to say, how does that change our work and what would that look like? I do like this screen. So since 1935, our federal government has focused on working with children and youth with special health care needs. And they've really talked about treating that whole child and by a care team of professional workers. And I like that focus. I think that sometimes we get into this mode of we're working with a family, they're our family, we've become a little bit maybe territorial, but in a good way, right? We really want to nurture and protect that family. But I love the idea of this team-based approach. And when we work with our care coordinators at our HCP program, we really talk about how do you do that? And what does that system look like if you are truly working in a team-based approach? So I always throw that in there. Those systems level considerations look like a lot of different things, actually. In HCP, which is our care coordination program, we have community-based care teams with knowledge of community resources and expertise and experience working with families of children and youth with special health care needs. They also have experience with making, receiving referrals, working with those other community-based groups and supports. They kind of know how things are working, what those processes look like, and they can speak to how do we get the work done? Who do we work with, and what is that process? And so part of the systems level component of that is really looking at how does our workflow look within our program, and how do we interact with others and communities. And really a lot of the work has been looking at those referral systems. Are we giving the right information? Are we giving a contact for someone to do the follow-up? When someone refers to us, are we following up, right? Are we telling them what happened, and are we encouraging that ongoing communication? We've also worked a lot on understanding roles and responsibilities of other care coordinators or case managers and developing shared plans of care. So sometimes we do similar work. And so if we know who else is doing that work, what does that work look like, we can have a whole different conversation, and we can negotiate who's going to do what and really shift that work, the workload for each other a little bit differently, and we can look at that differently, but also support the family differently. So again, at the local level with our work, we do feel like we have that position to help to influence some different changes with policies and systems work. And just really through that direct service of care coordination, it does give us a unique glimpse into what the systems and policy changes might be. And lucky for us, there's a framework around that, right? So this practice policy communications cycle just speaks to the fact that our practice can inform our policy change, but then sometimes policy change will also inform our practice. And so when we do that, we just really, we really think about that within our program, and we just know that from this experience over the last many, many decades, we really do have that ability to look at what's been happening, what do we like about that, what might be different, and how could that practice inform some different policy changes. But what we did find is that we didn't have a good handle or data on what SHINs might need across the state. So like we know what we're doing here locally and kind of at that one-on-one, but what's that bigger picture look like? And so before we could say, yes, this is what we need to do, we really started talking about what other impactful changes could we make, but first we want to learn more. And so what our team started back in 2016 was looking at how do we get more data, how do we get information on what's going statewide. So we incorporated a scan into a contract that we had with CU Medicine, and it's the same contract that helps support our specialty clinics. A statewide scan where we actually looked at, we went around the state and we actually talked to people in communities. Our clinic coordinators and care coordinators helped us bring families in. We did some family meetings, we did some community cafes, and we brought different individuals with us as well from CU Medicine and Children's Hospital. This is one of those first places where we really started reallocating some of our resources to intentionally shift that focus to more of a policy and system improvement. So how do we get the data to drive some of the new work that we wanted to think about? So again, we did this specialty scan, this 18-month process really worked very hard to incorporate community input, try to identify community needs. We looked at other ways to shift our contracts, and also found that some of the things we were hearing, we thought, oh, I wonder if there's funding for that. We went out and found some funding to help with some of these other things we were hearing. So, you know, like it's just cool, I think, to go out and hear from communities, what is it that you need, and then to try to be solution oriented with that. One of the things that we heard, though, everywhere that we went, was that access to diagnostic and developmental evaluation is tough in the more rural areas of the state. And by that, we were like, well, what does that mean? And it was a few things, but we also realized that as a team, we needed to learn a little bit more about the bigger system of diagnostic and of developmental evaluation before we could even talk about some of the diagnostic components as well. So, as a result of that, we really had to say, what is it the communities are asking for? So when they say that we're struggling reaching or getting developmental evaluation, what did they mean by that? And as we started talking and asking more about that, sometimes we realized that there was really some common, language was being used that was not being descriptive enough for us to know. Did they mean an educational evaluation, or were they talking diagnostic? We also wanted to learn more about what was currently available and what does this current system actually look like? Where do they touch? Where are their pain points? And so we wanted to kind of work through all of that. We also wanted to see how our work connected with those systems. So what is our role and how are we accountable to the work that is happening around developmental evaluation? And then of course, what could we do or try differently? Earlier, I also mentioned, just to recall, that the strategies for our program, and really, again, supporting communication and collaboration between systems that are working together, expanding access to information and resources, improving developmental screening and referral services. So within our program, and hold on a second, I just want to make sure, within our program, we actually have different priorities that we're working on. And so besides our care coordination component, we also work very closely with Michele's team at ABCD, and we have a developmental screening priority area where we work with county public health departments to implement different strategies to improve developmental screening within their communities. We also have our medical home priority that is really focused, again, that practice to policy and policy to practice around pediatric care coordination efforts around the state and what could be improved around that. And so we have a couple of different programs that we are, or pilots, that we're working on with Sandy's team and a couple of others that really work to see, you know, how could we improve things, the system component around accessing the diagnostic developmental evaluation. And so kind of working through some of those different things. And again, we really, the question for today, and setting this up, is really asking that question around, is there a diagnosis or is there a delay? And, or is it both, right? And so how do we make those referrals? Is it one referral? Is it two? And I think the argument is that it's simultaneous, right? So today Michelle is going to talk about the educational component and Sandy will talk about the medical referral component. Again, through all of this work, as we go through some of the opportunities that we've come across, is that we do think that there are opportunities to look for strategies to increase simultaneous referral. And we also think that there's opportunities to continue to improve communication and collaboration, particularly around those referrals and follow-up. To better understand systems, services, roles, and responsibilities. And so again, that's a component of today's presentation. To use common language. It is super interesting to be in a room with people who do this work all day and then still be like, oh, no, I mean a diagnostic developmental evaluation. And so we just want to really think about that common language and helping to make sure that when a family tells us, we maybe know the questions to ask to make sure that they're talking either educational or diagnostic. Building provider capacity. Part of the pilot that Sandy will talk about this afternoon that I'm really excited about is really looking to other providers out in the community and doing some training and coaching and support around the STAT tool to help to get earlier diagnosis and to help with some of the wait times and other barriers that Sandy's going to talk about. And so that is one of the other areas that we saw that, that's an issue. Families are trying to get to Denver, long wait lists. They have the travel component, they're missing school, they're missing work, all of those different pieces. And what could we do to, in some cases, to eliminate that extra travel and that extra trip? So we're looking at that too. And then of course, always keeping an ear and an eye out for different policy recommendations. Are there things that we could recommend to different groups, to HICPUF, to who might it be that we could do some work around to make some recommendations to improve those systems and just the work that you all do every day as well as you work with families. All right, so I'm just going back to those objectives so you can all see that before our next speaker comes on, and then we'll have some questions here at the end as well.
Good morning. As I said, my name is Michele Ebendick. I work for Assuring Better Child Health and Development. I'm going to dig in a little bit today on what IDEA Part B and C is, what's happening in Colorado before we move into the diagnostic evaluation. So I'll chat a little bit about the educational first. So first of all, what's the difference between developmental monitoring versus screening? Both happen among pediatricians. Developmental monitoring is a process of close and continuous observation of a child's development in order to identify risk for developmental delay. So it's a continuous. Every visit, that medical provider is constantly monitoring development. Where developmental screening is the use of a standardized developmental screening tool, and this is a point in time. And with the goal of identifying children with or at risk for developmental delay, with the purpose of referring to appropriate services. So that's a little bit of the difference, since I know sometimes it can be confusing, but that monitoring is ongoing and screening is a point in time. So the American Academy of Pediatrics recommends developmental screening happens at 9, 18, 24, or 30-month well child check. So our goal is to have 3 screenings by the time the kiddo is age 3. The most common tool used in Colorado right now is the Ages and Stages questionnaire. That's among medical providers, I'd say home visitors, as well as some early learning programs. So it definitely is widely used in Colorado right now. We have a little bit of data. So 49.7% of parents in 2017 reported that they completed a questionnaire about their child's development. And if we look at Medicaid and CHIP data, 41.8% of children received a developmental screening in 2016. And we're doing pretty well as a state of Colorado. Of course, we can always do better, but we're doing pretty well. So when we do have some of those concerns and wondering if there is a delay with our kiddos, we have a couple options. And so I'm going to break down the Individuals with Disabilities Act, IDEA. Part C is for birth to age 3. It's also known as early intervention. The services are provided by a CCB, which is a community center board. So they're the umbrella, and underneath that is the program of early intervention. If a child were to qualify for early intervention, they would result in an individual family service plan, and that would outline the goals for the family and the child and the services that they would be receiving. And the developmental services are provided in the home or the natural setting. So that could be a child care center if that's where the child spends most of their time, or it could be in the home, and they are family centered. So it's working on that child-family relationship component as well. So then part B is for ages 3 to 21, and that's special education when you hear IDEA Part B. Services are provided in the school district in which the child lives. When a child is found eligible for Part B, they receive an individualized education plan, IEP, I'm sure you've heard that. And the setting that the child will receive the services are in the educational classroom in a student-centered way. And as we move forward, we'll talk a little bit more about what happens with our 3 to 5-year-olds known as child find. So when making a referral with a family, we always want to engage the family in the referral decision making rather than telling the family where we're referring them. We'd like to give them some options because not every family wants to do the same thing. So engage the family in their options. Completely fill out the referral form. I know it sounds silly, but they aren't always filled out. So we want as much of that information as you have on the child included on that referral form with correct contact information. Because again, the CCB or Child Find will be contacting the family to set up the next steps. If a screening was done, we want to attach that screening with the results to the referral, as well as any other diagnostic information if it's known. So the more we can share, the better. And then we want to educate the family on the referral process and next steps. So what's going to happen after you send that referral out to, on behalf of the family? What should they expect? And we'll dig into that in a little bit. So I'm sure you're wondering, where do I get the referral forms? How do I know where to send the child? So this first link is where you can find both early intervention and the Child Find CDE referral form, both in English and Spanish. So that's the most up-to-date, best place to find it. For early intervention, when you're making a referral, this is the link you'll want to use, and it'll allow you to put in where the family lives, and it'll pop out which CCB or early intervention program to send the family to, and then it'll also give you the fax number and all that pertinent information. For Child Find, when you make a referral, it's to the school district in which the child resides. It's not where mom and dad work, not where they go to childcare. It's where their home is and the school district in which they're at. And there's a Child Find directory online that you can kind of click through, and it'll help you figure out which school district the family's in, since sometimes I know it can be confusing. So that's where to find the referral form so that we can make sure that we're accurately filling it out and sending it off to the right place. So the early intervention evaluation, this is this piece of what are you going to explain to the family when you're making the referral. So early intervention will contact the family. And a service coordinator is assigned within 3 days. So that's someone that's going to coordinate everything happening with this child. At that time, after the service coordinator has been assigned, a referral status update will be sent. And that would be sent to the provider or the early learning provider, whoever made that referral, that says service coordinator has been assigned. The next piece that would happen after all the consents and paperwork is done is that the child would go through the evaluation, if the family consents. And if the child is found eligible, the IFSP meeting will happen to determine the outcomes and the services. And that's where everything in that meeting will be written up into the IFSP, that plan that I spoke of earlier. And then once that's done, that's a 45-day window, then they have 28 days for the first visit to be with the family by the service provider. So it is a 45-day and then 28 days. And then at that time, this referral status update will be sent again if the family consents to share that information. So that's kind of the continuum, but it's helpful to tell our families when we're making the referral with them of someone will be calling you and here's what to expect, because often, families don't want to answer those random numbers that they get. So the more we can educate them on the next steps, the more likely they are to answer the phone and decide if these services are right for them and their family to move forward. Yeah, so they have 3 attempts to contact the family. Typically the first attempt, I want to say, and Laura can correct me if I'm wrong, is within 7 days, but they do, most places do 2 phone calls, and then the third will actually send a letter as well in case the phone option isn't successful for the family. And each CCB is a little bit different and they have federal regulations, but some try to accelerate that process, obviously, to get it through. So who is eligible for early intervention? If the family is eligible, the child has to have a 25% delay in an area of development. So one area of development. They can also be categorically eligible. And this is a condition or diagnosis associated with a high probability of a delay. The database link down here has the most accurate and up-to-date list of all the diagnostic conditions that are categorically eligible. So definitely click on that. It's a little overwhelming, but it has everything for a provider to know. And then also in Colorado, a child who is a parent with a developmental disability can actually also be eligible for early intervention, and that's determined by the CCB as well. So there's a couple different ways that kids qualify for early intervention. So we're going to switch gears and move into IDA Part B to talk about the school district end of things. That was early intervention, and now we're going to move to the school district. So the school district or IDA Part B have a couple roles as child find. For birth through 2 years of age, they assess the level of development. So they're actually doing the evaluations for those kids under 3. So they do the evaluation for early intervention kiddos. And then when the kids are 3 to 21, they determine eligibility for special education services and support. And for today, we're going to talk about the 3 to 5 young kiddos, that would be special education preschool. Some of you might know it as child find. So they do have 2 roles, but we're going to move into this 3 to 21 role specifically. So for child find for ages 3 to 5, once the referral is received by the school district has an option of doing some screening to gather some additional information on this child, because they're asking themselves the question, do we have enough information to move on to a developmental evaluation? And if they don't feel they have enough information, then they can do some additional screenings to gather some more information for families. So just because a referral is sent doesn't mean that the child's going to go directly to evaluation. They might do some screenings first, and the school district might say, the screenings have determined we don't need to move on to evaluation, or yes, we do need to move on to evaluation. And this is an optional step. It's not required, but many school districts do this step. Then the child would go through the evaluation, and if the child is found eligible, they'd get that IEP that I mentioned earlier. And for ages 3 to 5, in this case, they would receive special education preschool. So the child would be in the preschool setting or classroom receiving their special education services as defined in their IEP. So who is eligible for special education preschool? So it's a child ages 3 to 5 who have an educationally relevant delay that prevents the child from getting the full benefit of general education. So it really has to have that end piece that we need. The kiddos that are qualifying would benefit from getting additional support for general education. So that is child find or IDEA Part B for ages 3 and 5, preschool special education in a nutshell. And from there, since we just went through all the educational piece for an evaluation, we're going to have Sandy come up and talk more about that diagnostic developmental evaluation and how they're different and when to refer simultaneously.
Okay, thank you. I appreciate the opportunity to be here. I'm Sandy Friedman. I'm a developmental pediatrician at the university and at Children's. And I'm going to focus a little bit more on the medical diagnosis. So as Angie said, there's a big need, not only in Colorado, but everywhere for developmental assessments. There's long waiting lists, people are frustrated, and especially for young kids, because we already know the sooner you identify somebody and intervene, really the better the outcome. So there really is an issue with appropriate access to assessments, recommendations, and then intervention. I'm going to focus a little bit on the medical, but when children come in through developmental pediatrics, we do a lot of team visits with the developmental pediatrician and a psychologist. We also have teams that have speech and OT and physical therapy too. It's not just administering a test. I'm not the psychologist, but you know, it's important to get a really good history, observe, do testing, but really use clinical judgment, even for autism testing, like the Autism Diagnostic Observation Schedule. Clinical judgment supersedes even the test score. So you really need to gather information from the school, from the family, from a lot of different sources. And also just to bring up, the school system provides a quote unquote medical diagnosis. When they come to see us, we provide an educational diagnosis. When they come to see us, we provide the medical. Now it's the same child, and so you wonder why should there be two different diagnoses? And usually there aren't, but sometimes there are. I think with the educational diagnosis, they talk about what type of supports and strategies the child needs based on their presentation. And I've seen children where we've provided a medical diagnosis and the school hasn't, but I've seen it the other way around too, where the school has provided an educational diagnosis, but we haven't. The main thing is that the child gets what he or she needs and that we work together to support the child and the family. So looking at the reason for a medical assessment from a physician's point of view, it's important to understand etiology for the developmental problems. By doing that, we could talk about recurrence risk for the family and have some genetic counseling implications. A lot of times families come in and we know autism does tend to run in the family, and often the mother is pregnant with their second child when they come in with their first child, and they really want to know about recurrence risk. Sometimes with a specific medical diagnosis, you have prognostic information you could provide, certain treatment options. And if you have a specific medical diagnosis, you don't have to do a million different tests. If a child comes in, you say, oh, this child looks like he has a specific condition, then you deal with that condition. You don't have to run a lot of unnecessary medical tests. And it also guides monitoring for other tests and management. There's a number of research protocols going on, especially for things like Fragile X, as well as for autism. And if we identify a unifying medical diagnosis, often there are support groups for families as well. So standard of care, this is medical care, is that children with global developmental delay or intellectual disability require consideration of a medical evaluation. And I'll talk a little bit about that. And children with autism spectrum disorder, this is standard of care, not everybody does this, require consideration of a minimum of some genetic testing because there's a big genetic component to its presentation. It should be done stepwise. You don't do everything at once. It costs a lot of money. You do a lot of unnecessary tests. You have to have a reason for doing it and kind of have some type of formulation of the problem in terms of what's going to guide your medical assessment. And two kids could have the same evaluation, but they don't require the same the same diagnosis, but they don't require the same evaluation. It's really based on their presentation. So there's multiple etiologies for developmental problems, autism, and this could occur prenatally, during the birth process, which is perinatally or postnatal. Other than genetics, genetics, you're born with it, although you may not identify it till later, but metabolic in terms of enzymes and metabolism of proteins, sugars, and carbohydrates, infection, toxins, trauma, environmental, could occur prenatally, perinatally, and postnatally. So that's why we really need to get a good medical history. So we could have a kind of a working hypothesis about what is going on with the child. And so we always start with a good developmental history, and we really try to dig down. Parents' concerns are the most important. Like Colorado uses mostly the ASQ, ages and stages, but there's another screening test that's approved by American Academy of Pediatrics called the PEDS, and it's really based on parental concerns. Because usually if a parent is concerned, they know their child better than anybody. Something is going on. It may not always be exactly what they're concerned about, but you really need to listen. And then you do a history wanting to know what happened before the baby was born, what happened during the birth process, what happened afterwards, which is going to guide your medical workup. And then obviously we always do developmental milestones, but if you have more than one child, you don't always remember the developmental milestones. But what I like to do is see that developmental trajectory, because has it been slow and steady? Was there a plateau? Was there a regression? Because that's going to drive what type of workup I'm going to do with the child. Medical history, if the child was in the hospital a lot, was born with like congenital diaphragmatic hernia and had a lot of medical procedures, it's going to affect development. Family medical history, we do a 3-generation family medical history to look for different type of genetic conditions that run in the family, and social problems. The most common cause of mild intellectual disability is social deprivation. And so it's really important to look at psychosocial problems as well. Okay, and we obviously do a physical exam. And so this is just to show that we look at the child to see if there's anything that's a little bit distinctive. And the more what we call dysmorphic or distinctive features, the more apt you're going to have a genetic component to it. And so about 40% of kids with intellectual and developmental disability have 3 or more dysmorphic features. You don't have to have them to have a genetic problem, but you really need to look at how a child looks. We look at growth parameters, so weight, height, head circumference. Height and head should be relatively proportional. So if the head is at the 90th percentile, but the height is at the 3rd, that child has a big head relative to height, and that's going to drive my workup too. If they're not growing well, you want to look at what's contributing to poor growth. Any positive physical findings, like a large liver or a spleen, and then any positive neurologic findings. We know developmental problems is neurologically based. We don't do an MRI with everybody who walks through the door, but if we have somebody with abnormal neurologic exam in terms of reflexes, muscle tone, movement patterns, that's going to guide our workup to maybe consider imaging studies. So then after getting all that, we start thinking about what do we think is going on. We have wonderful psychologists we work with who do great testing, and based on our history and our physical exam and the results of testing, we determine what's the working hypothesis for etiology, and that's going to drive our recommendations for workup, for medical workup. And our psychologists will also, based on their testing, provide recommendations for intervention as well. And this is a little bit overwhelming, but just so that you know, there's standards of care for workup for kids with intellectual and developmental disabilities. According to guidelines, everybody who has intellectual disability or global developmental delay of unclear etiology ideally should have some type of genetic test. Everybody doesn't do that, but they should. And or if you see a child and they say, oh, this child looks like Down syndrome, you could just do a karyotype of chromosomes. You don't have to do every test under the sun. But if you're not certain, then it recommends going on and doing a microarray and doing other type of genetic and clinical tests. If you make a diagnosis, then you address that. If you don't make a diagnosis, then you go on to the next level of assessment. So there's tests for inborn errors of metabolism, particularly for kids who lose developmental skills or who have a long plateau. And then sometimes we'll do imaging studies if things are negative, or if somebody has a very big head or a very little head, we'll do imaging studies. We don't do CT scans. It has high radiation, and that's more for trauma. We really will do MRIs because you get better resolution of the brain tissue. And sometimes, no matter how big of a workup, we don't find a unifying medical diagnosis, but that doesn't mean we may not at some point. Genetic tests have gotten better every year, and so sometimes a lot of our geneticists, if they don't find anything, they'll say, come back in a year and we're going to reevaluate you. And I've seen kids who initially the genetic tests were negative, and a few years later they have more refined tests, and then we could find a unifying medical diagnosis. And then everybody should get hearing tests, anybody with developmental delays. I think you all know there's more kids diagnosed with hearing problems when they enter kindergarten than in the neonatal period. Make certain vision, EEGs if there's concern for seizure or significant regression, looking at infectious agents or toxins, how they're growing. So if I have a child with significant developmental delays and they're little and they're not growing well, I'm worried, and they have a history of constipation or dry skin, you really need to get thyroid function tests because that could affect both development as well as long-term outcome. Looking at nutritional kids and hematological kids with severe anemia have developmental problems. They're at risk for developmental delays. So that's, we kind of look at the whole picture and guide the workup that way. And then we refer to other specialists. If I see a child who comes in and I know they have some syndrome, but I can't quite place it, I may just send them right to genetics, because rather than me poking the child for blood and then going to genetics and have another poke, we'll try to do it all at once. But usually we will start with some basic genetic tests. And even if the tests are negative, but you have a high index of suspicion that something's positive, we will refer to genetics. And then we'll refer to different specialties based on their presentation, or if there's other things that are more complicated, like an ongoing seizure problem, cerebral palsy, we'll refer to either genetics, neurology, or rehab medicine, or other subspecialties. So that's like the medical piece. But looking at the global piece that Angie initially addressed, there really are long waiting lists everywhere. It's not just Colorado. It's a nationwide issue. And the rate of disability has increased over the years. There are workforce issues. There's not enough people to go around to test all these kids for these big diagnostic assessments. So does everybody really need these big diagnostic assessments? And I will say no. I think you could fine tune it. I think there's certain kids who do, but I don't think everybody does. And I think our job is to support the community to be able to be comfortable to do more. We can't, there has to be a better system. And there are certainly disparities and underserved rural, frontier, and urban areas that need our help as well. So in Colorado, it's similar to the U.S. There's, in terms of just children and youth with special health care needs, that's developmental issues, but that also includes medical issues, kids with diabetes, renal failure, things, medical issues too. There's about 18% of the kids in the U.S. and Colorado that have special health care needs. But when you ask parents, does a system work well for them in terms of getting what their child needs? Only 14% or so say yes. So something needs, it's a lot of complexity, and even we have trouble navigating it. Just think about a family. And then in terms of a medical home, nationwide, people will identify as having, like 43% will say they have a medical home where their primary care provider really coordinates care and helps them navigate the system. And in Colorado, it's a little better, almost 47%. So right now in the US, there are 74 million children with developmental and behavioral problems. So that's about 15% of all children in the US. That's a big percentage. And there's, which is about 11 million children. Nationwide, there's 800 board-certified developmental behavioral pediatricians, nationwide. And so that means each one, and a lot of people work part-time, or there's like almost 14,000 children per developmental pediatrician. It's not practical. So there really needs to be a different way to look at it. And also, there's been surveys of developmental pediatricians, and there's concern about burnout, being overwhelmed, not having enough time to evaluate kids, having a long waiting list. What could we do? And actually, there's more jobs in the country for developmental pediatricians than there's people to fill them, because a lot of people don't go into the field. It's not a high-paying field, and it's not, there's not a lot of procedures, and you really have to love what you do to go into the field. So as Angie mentioned, we are forever trying to figure out how could we meet this need. So Angie and a number of people from the hospital went around, and they talked to people throughout the state. There's a big need for developmental assessments. There used to be regional clinics. There's not anymore. So we really need different models of care. And so we actually were lucky enough to get funding through this upper payment limit funding that's kind of administered through HCPF, but goes to the university. And we applied for it like a grant, and we got funding to look at to support different models of care. And even outside the funding, in our clinic, we tried to look at what could we do better to get more kids in or get them to the right place. So for school age and adolescent kids, those are the most complicated kids that we see, because a lot of them have a lot of comorbid psychiatric problems and behavioral problems. And a lot of times they come in for these long interdisciplinary developmental assessments, and then you realize they should have been in psychiatry, or they should have been somewhere else, or they probably only needed a little piece of that evaluation. So right now our psychologists are doing like this intake model where they come in for briefer assessments, and they will get a history and they do some focus assessment, but they will say, yes, you need a big eval, or no, you really don't, you just need this, or really you don't need us, you need to go somewhere else. And about 30% of the kids we've been able to take off our waiting list altogether. And the other percentage we've been able to do, for a large percentage, more focused evals. Some of the kids really are very complicated and need a big assessment, but not everybody does. And so we're actually part of the Developmental Behavioral Pediatric Research Network, and we're working with, I think, 6 other sites looking at the ADOS to say, could developmental behavioral pediatricians' judgment, does that correlate well with results of ADOS? Because, you know, sometimes you could diagnose a child in the elevator, or in the waiting room. You don't really need a huge mega workup, but parents really need a lot of explanation and need resources. They need somebody to talk to them about it. So you really have to kind of find a way, how could you support the child and the family, but get more kids in quicker, so that everybody does, so the waiting list will go down, especially for the young kids. So we actually, with this funding we got, we actually are starting to train. We actually have trained a number of advanced practice providers throughout the state, in rural and frontier, and actually at Denver Health too, in administration of the STAT, which is a secondary screener. It's screening tests for autism in toddlers and young children. It's a secondary screener. It's not a diagnostic test, but there's been a lot of nice studies to show it correlates very well with the ADOS, especially if you get some other information to support it. So Ann Reynolds got a small Autism Speaks grant and the health department also gave money, where we did trainings for advanced practice providers on and we bought the kits for them, and they had online training, and then they came in for a full day conference on autism and different issues related to autism. And then we continued with ECHO, because people know what ECHO is. So we had twice monthly ECHO where we talked about a subject, and we did case presentations, and we reviewed some of the STAT results to support the advanced practice providers. It's not instantaneous, because I find that sometimes you really have to understand a number of issues, and some of our advanced practice providers have called the diagnosis when we probably wouldn't have. And yes. Oh, I'm sorry, nurse practitioners and physician assistants, okay? Because a lot in rural communities, they don't have pediatricians. And there's wonderful advanced practice providers out in the community, and some of them are really want to do more. So we have worked to collaborate with them. We just finished a series of 6 echoes, and now we're going to start again. And initially we had it open only to those people who did the STAT training, and now we're opening it to other people. And then we're also going to have a community of practice, so people could call in and talk about issues in terms of assessing kids. And then, just to make certain, one of our psychologists is going to certain kids where there's a diagnostic dilemma. She's going to open up slots to specifically see those kids, to see what the correlation is between the STAT results and more diagnostic assessment. I mean, we're in the infancy stage here, but we're working on it. So we also have done some telehealth, where we have gone into like Durango Pediatric Partners of the Southwest. They have a wonderful telehealth setup where initially our developmental pediatrician, and now we're going to have a developmental pediatrician, and now a psychologist will actually see a child, do a history, and then if they could refer them to resources in their community, they will. If they could call a diagnosis, they will. We have a one-day clinic where people come in from all over the state, and everything is done in one day, so they don't have to come back. But sometimes they don't even need to do that, or they just need a more focused assessment, and it's an unnecessary trip. So we're trying to expand the telehealth. We also, starting next month, we're going to be doing e-consults, where primary care providers, either nurse practitioners, physician assistants, pediatricians, family docs, could email us with a diagnostic question in a HIPAA-compliant way, and we could respond. This is our suggestion. So I think pediatricians want to manage their own patients, but some are more comfortable than others to do it. And so we really want to be able to support those who want to do it. We also, for children, there's a pediatric care network of primary care providers, and they actually, Children's Hospital provides them with EPIC, our electronic medical record, and I think there's 34 practices throughout the state. And so one of our psychologists is going to be working with each practice about how do you do a good history for autism and doing some education and support. And they're very excited about having somebody support them. We're not trying to increase the burden and load to pediatricians, but we're also trying to have children cared for within the context of their medical home, you know, if they can be. And if they can't, we want them to come to see us. But I think we'll never have enough capacity to see everybody, so we really need to look at different models of care. Okay. So, again, we want to support primary care providers. We don't want them to feel burned out or feel overwhelmed. There are practice guidelines, but you know, pediatricians are very busy, and and family doctors, they see kids quickly. But I think if they would have somebody to back them up and support them, they would be able to manage a number of things. We need people who want to do it, because some people don't want to do it. And so we really need partners who are motivated to do it. And then there's also, we need to look at billing codes. So, you know, the developmental screening tests, there is a billing code, but if you do the STAT, there's even another billing code where you get more money. There's a new one now. It's 96112. And then there's 96113 if it's over an hour or whatever. And you get more funding. You have to document what you do and write a report, but there is more funding that will go in the practice. So, you know, somebody has to be interested, and we thought, you know, nurse practitioners and physician's assistant, we thought they would be more interested in doing it than like the pediatrician or family doc who, and it seems like they are. And then they actually could bill for their time. And so, you know, it's not a ton of money, but it is something that they could be reimbursed for. We're going to be evaluating our primary care. So part of this is evaluating, is not just doing it. We want to see if it makes a difference. So we're going to see, do primary care providers like it better? Do parents like it better? And how effective is it in terms of the quality of services? And so we're looking at different metrics that we report to because the health department is also providing us with some funding too. And so we need to report outcomes to the health department. We also need to report outcomes to the funders as upper payment limit funders. So, and because if we can't, and the main thing for that particular thing is underserved. Medicaid, patients on Medicaid, because those are the most vulnerable. I mean, we'll see patients without, but for this particular project, we're really focusing on patients with Medicaid. And then it's important to share best practices. We're already learning things that we could have done better. I mean, it's almost like quality improvement, like a PDSA, you know, something works, you do something, you could do it better, you try it again, then you evaluate it. So a big part of this program is evaluation. And so we're hoping that over time, we'll be able to improve systems of care, not just individual care. Okay, I think I went too fast, maybe. Okay. Anyway, so I think we're going to open it up to questions for any of us. And also, do you have ideas? Because I mean, you all are out there doing it, and we're really, the whole thing is we should be collaborating together. It's, you know, there's enough to go, it's not a competition, there's enough to go around, and so how could we best support families and the child? Yes. Mm-hmm. Mm-hmm. Yeah. I think they should. I absolutely. Oh, okay. So we were talking about, tell me your name again, forgive me. Bonnie Dodd Benson works for Sewell, which is it's a preschool, but it's a diagnostic center for children to rule out developmental problems, autism, as well as a preschool. And she also works for the school system. And what she said was the school system needs to identify autism, and they use DSM-5 criteria. And why can't the school system and the medical system coordinate better? So it would be good. I think it would be good. The issue is we're not always, some school systems, you know, it's local control. And it's not even some school systems. Different schools within the same school system have different resources and different assessments. I mean, Rocky Mountain Human Services for early intervention, they'll come in and they'll do the ADAS and they'll do all this wonderful diagnostic testing. And then there's some schools will do a lot of standardized testing and behavioral questionnaires and adaptive testing and ADAS, and they do a wonderful job too. Not all schools do that. I came from Massachusetts. And about 9 years ago, and things have improved a lot since that time. But school systems uniformly, if there was a need for cognitive or achievement testing, would do it. I mean, I know there's response to intervention, and you don't always do all this testing right away, but there wasn't as much assessments being done in the school that I was used to. I think things have gotten better. And also in terms of doing, it's more than, so you could apply DSM-5 criteria, but it's more than just DSM-5 criteria or the ADAS. And actually the ADAS, you really have to be reliable in administering the ADAS. And we've seen children who have got both ways, not to say we're the end all and be all by any means, but who have gotten the diagnosis we don't agree with, and who hasn't gotten the diagnosis and we think they need it. The main thing is the child gets what he or she needs, but I think there should be better. And the issue is a lot of insurance wants a physician in order to get behavioral treatment, want a physician to give the diagnosis, but a primary care doc could do that too. Yeah. Yeah, please do. Yeah.
A little bit awkward. So I just want to say that I think that sometimes it feels a little bit all or nothing, and I think that the instance that you just described is a really good opportunity to think about, you know, just negotiating and talking about that. So is there a school you could start with and work with to figure out what would that collaborative process look like, and how might we go around that? And so I think that that's your opportunity to think about that. I think Sandy's point was perfect as far as the idea that not perfect, but on point is what I'm trying to say. You are perfect, but on point as far as the idea that we have so many different systems, and there is that issue of local control and how everything, you know, we're all working towards the same thing, but we do it a little bit differently. And so while we may not be able to jump in and just do a blanket, this is the process, you could have, you know, negotiate that process at the, you know, at every point of contact, I guess, which is hard, but if you do it one at a time, you know, it's really doable, and you might be able to identify where. But I like the idea too, I think.
Yeah. And I just want to say one other thing. Some kids come in and they've had a huge assessment. We could take that assessment. Maybe they'll just see the developmental pediatrician, and that would be great. We'll take it. I mean, and you know, we'll observe, we'll get a history, and we'll take it. We've had kids who've had the time they called for the appointment, they got another assessment, a whole big assessment, you know, cognitive testing, ADAS, adaptive testing, behavioral, and they'll come in with all of that, and we'll think, somebody else could have used this slot. I mean, you know, maybe, you know, we want, you know, so we don't have a lot of bandwidth to call everybody over and over again, do you have a new assessment? Well, we have patients who've had another assessment and they'll say, we still want to come in and get another opinion. So then what? I mean, you can't say, I guess you can say no, but we don't say no. But we would prefer that maybe if they just want that medical piece, a medical workup, come in and see one of our physicians and we'll take that evaluation and we'll give the diagnosis. And I think there needs to be, I think parents need to be assured sometimes that they have a lot of information. Let somebody look at it and evaluate it. And actually, some of our psychologists also will take evaluations and look at it, and sometimes they'll spend time explaining it to the parents rather than retesting. You know, certain tests you can't even repeat in an X amount of time. So we would prefer not to recreate the wheel and do more testing. I think, anyway, we could do better. Okay, yes, okay, yes.
We provide primary care for about 4,000 kids with complex medical needs. So we provide primary care for kids with complex medical needs. And so we're always, my biggest thing is trying to get kids services and making sure they have the testing. And my question for you is, with this project, have you looped in the community center boards? Because they're the ones that are looking. Most of our kids are on Medicaid or seeking Medicaid for waiver services. And they want testing, especially when they turn 6 years old. They have to have, instead of a developmental delay diagnosis, they need a developmental disability diagnosis, with which, even if they're clearly profoundly affected by whatever their problems are, they want this formal testing, and not all the community center boards see the same testing the same way. And so I'm wondering if that's
okay. Good question. And I love special care clinic. And so, like a lot of times, if they don't have IQ testing, they need adaptive skill assessment. And so we are working with primary care providers, which advanced practice providers are in many locations. And we're not working with the community center boards, but we're supporting them to work with the community center boards. We haven't really done adaptive skill assessment. It's something to think about, though. And some of it could be patient family questionnaire. A lot of times we will actually send a family a questionnaire, score it, and then tell them to take it to their community center board to show that they're eligible. So it used to be it was just IQ, but like kids with autism, some kids have an IQ within normal range, but adaptively they're functioning really low, but they're eligible for services if their adaptive skills are lower. And so we'll do adaptive skill assessment, but we haven't done this. I mean, this particular project is really limited to working with primary care providers to increase their capacity to manage kids, and we haven't actually addressed adaptive skill assessment. So, but it's something to think about. Oh, okay, I'm sorry. So okay, I'm gonna give you the mic.
Hi, my name is Dr. Claire Dumke. I'm a psychologist in the community. I co-own an agency called Insights Colorado Assessment and Therapy. We actually refer a lot to Sewell. I guess my question is around trying to unburden pediatricians, and also we hear from families so often that they're so frustrated by the waiting lists. Children's is anywhere from 1 to 2 years at a good day. But we hear a lot from That's good. That's good. What do you think the best way for smaller agencies like School or Insights is to collaborate with bigger agencies like Children's to kind of
So when patients call, we have an intake process, and then we give them names of other places. We will talk about, give them Sewell, give them Legacy and Parker. You know, we always say, have you had a hearing test? That's one of our first things, but we'll give them resources to call. I mean, we always do that. We don't have a corner on the market, and there's enough to go around. In terms of direct collaboration with private agencies, or I mean, other than, using the same, other than providing them with names and phone numbers of the different places to call, you know, I don't know how do you envision that? Yeah.
we're new to the Medicaid world, and so we're just, I think, in the process of, you know, how do we access, how do we support as many families as possible in the community? And so I guess that was more just my question is, I don't know if this is related, but so Sewell, 90% of the kids that we see are Medicaid. Sewell's a nonprofit, so we're getting supplementing. A big issue recently, we see both Denver Health Medicaid and straight Medicaid. We've had to stop seeing Denver Health Medicaid because we're not getting paid. And recently that has been a problem with regular Medicaid too. And so in terms of access, we do 2 evals a day. So we've really kind of streamlined our diagnostic process. You know, we're flipping through kids really fast. It's intense. But now we're running up against this problem where we're not getting reimbursed. And so how much longer can we continue predominantly serving the Medicaid population when we're not getting paid? Well, that's a big question.
Or you're getting paid very little. Yeah. And they don't pay. I mean, we have like over 50% Medicaid. We don't turn anybody away. And we lose money with Medicaid because they don't, you know, they don't pay. They pay at a very low rate, but we don't turn anybody away either. And it's frustrating. So if we could have more people in the community do certain things, I think it would be better. We also have this RN bookend project right now. I just remembered. So what we're trying to do is we have, rather than having just the physician go in and do like a consult, or a follow-up, we have a nurse go in first, gather some of the information. The physician comes in, does a medical history, physical exam, gather information, and the nurse comes in at the end to kind of talk about recommendations or whatever, so that the physician could see more kids. And so we're in the middle of that pilot too, so that rather than seeing in 1 hour 1 kid or 2 kids or whatever, they could see 3. I mean, so we're really, you know, it may work for certain age group, but not other age group. And again, the e-consults, Angie was saying, talk about the e-consults. That's medical provider to medical provider. So, and that's going to be rolled out in May, but they have to be on Epic.
I guess I brought that up because I think the question you asked was, how do we collaborate differently with other smaller entities that are doing similar work? And I think that e-consult platform might be an incentive for you to use Epic and get on, you know, and participate in that way. But it might also be a way for you to provide your expertise and support some of these other entities once the project has been piloted and tested and is up and really running. So it's just the idea.
The EPIC is for medical offices. No, it goes to primary, I'm sorry, it goes to primary care. But if your patients are part of the pediatric care network, that could all, you know, you could work with the primary care provider. Okay, you've had your hand up.
I'm Marcy Willard with Clear Child Psychology. We're a private practice, and I also worked as a school psychologist for a long time for grades K through 8, doing evaluations within the schools and autism identification within the schools. And the big challenge that they have there is very similar to the pediatrics. In the ADOS is too much for most schools to be able to do, and they get a team trained, and then one person leaves, the psychologist leaves or the speech therapist leaves, and they're kind of right back where they started without having resources. And so a new model is being kind of rolled out where they do a really extensive screen and then look for those areas that identify them for the IEP. And it's a really nice evaluation process that could then be turned over to a pediatrician or to Children's Hospital for the diagnostic piece. And I think that's really kind of, that's their biggest hurdle, and it's very similar to what's happening in pediatrics of saying, you know, we can't spend an hour and a half on an evaluation, and for schools they can't pay for the training to send out, you know, 6 people on their autism team to go to the autism training, the ADOS training, and then come back and be able to stay with the schools long enough to administer all those tests. And again, there's a huge population of kids, right? So that's so many ADOSs that you'd be doing. And so it's just it's not feasible. And so I like your idea of having it be more of a, take what they do and have it be more collaborative in terms of, this is a beautiful screen. You have pretty much everything you need except for the ADOS and the really clear diagnostic tools. So I think that would help.
Hi, I'm Nicole Pearson. I'm also a psychologist in a BCBA, and I relocated here about 1.5 years ago from New York. And I think similar to what we've been discussing, one of the challenges, I have part-time private practice, but I also work as a psychologist for a school for children with autism here, a facility school here in Denver. And one of the things I found, which is interesting, I think, is what we're discussing is how can we, you know, the ADOS and ADIR are considered kind of gold standards, but they're not required for diagnosis. And I think that's the difference where us as practitioners, I've been working in this field almost 15 years. I do developmental evaluations like, you know, like the Mullen, like other types of the HELP, looking at, you know, ages and stages where you're looking at milestones, you're looking at that social communication. I think for us as practitioners, looking at some other criteria and best practices for that would help streamline those evaluations, because I know my challenge of not taking Medicaid for these evaluations, so I want to help the low income population because that's just such a tremendous need, is that, you know, that it's so time consuming if those things are being required and it's not something that I can devote 8 hours to doing and get paid $80 or something for that time, right? So it's, I think, figuring out as practitioners, how do we disseminate best practices with the medical community to say we can do these evaluations, we can provide kind of like what you were saying with, I don't know what your screenings are in the school, but same thing, you know, we're getting all the information that we need to be able to provide a reliable diagnosis and get those kids started with services, which at the end of the day is what they need, right? So thinking through that, I think that's why I wanted to come today to hear, you know, about this, but I think, you know, we can do that. We all just need to be figuring out what that is and disseminating that to medical providers, to families, to let them know that, you know, there's practitioners out there who can do these things and they're valid evaluations.
My name is Mary, and I'm a school psychologist also, and we were lucky enough to be one of the first school-age teams that JFK trained to do autism evals, and we've been able to keep capacity up. But I'm working in the eastern part of Colorado, and along the lines of that coordination, I'm wondering if you have a map or information about who are the different providers that you've trained in the more rural areas, because that would, having that information would allow us to coordinate.
So right now we don't have anybody in Eastern Colorado. We have people more on the western slope. Edwards, I think Durango, I can't even remember all. Where? Grand Junction. And it's really people who have indicated they're interested. And it really, we train them on the stat. Just because you do a training doesn't mean you know how to do it. Just like with the ADOS, I mean, not to say they don't know how to do it, but they have to practice, they need to get feedback. And and that's what we're seeing, that you could do online training for the stat, but doesn't mean you're an expert yet. So we're trying to support people. And again, it's a screener, it's a secondary screener, it's not a diagnostic test. But if you get a lot of other type of collateral information, it may help with the diagnosis. So this is a pilot project. And so we have, like right now, we just have a handful of people, and we'll see if we're going to expand it. We have actually questions from people online. So, okay.
So the first question online comes from Carol Meredith. Could a school psychologist do a stat?
Yes. Hi, Carol. It's Sandy. Yeah, I mean, it's training. It's available to anybody. It comes out of Vanderbilt. It's a secondary screener. It's not a diagnostic test, and probably a school psychologist doesn't need a screener. I mean, they probably, I don't know. I mean, we have school psychologists here, but they have a lot of like diagnostic expertise that maybe they don't even need. I mean, the secondary screener. It depends. I'll let the school psychologists here let me know what they think. But they can, anybody could do it. I mean, you could order it online and I mean, it's not cheap, but you could then do the training online. And we actually purchased it for everybody who did it with this funding we had. I'm just gonna, okay.
This question is from Ted Issue, I believe. What role do neuropsych evaluations play in the IEP development? I work with a pediatric stroke population, and the wait time for neuropsych evaluations to help assess the kiddo's development is several months to a year or more. Are there other community resources for neuropsych evaluations that families can tap into?
So our psychologists are not neuropsychologists. Their neurology has the neuropsychologist, they essentially, you have to have a medical diagnosis for them to see. So kids who've had stroke or kids who have had brain tumors or some other medical issues. DU has a wonderful program where they train neuropsychologists, and a number of our psychologists have been trained there, and they see patients. I think their postdocs see them with supervision, and it's a nice program, and we've referred people there. If other people think of other places or private in the community, but I know that the DU, and actually at Children's, through neurology, they have neuropsychologists, but also through physical medicine and rehabilitation, they have neuropsychologists there too. So, kids have different type of brain trauma, like traumatic brain injury. I don't know. Does anybody else have a suggestion? Quiet. Okay. So, yeah.
From a policy perspective, is CDPHE looking into anything related to the 2012 READ Act and then in parentheses, assessments for children with significant reading deficiencies.
I'm going to give this to Angie, since she represents CDPHE.
So I'm not sure. Our group has not looked at that, and I'm not sure if there are other entities or groups that are doing that, but I can ask. I'm good at that, so I'll go back and find out.
Actually, one of our developmental behavioral pediatric fellows has a project where they're going to start doing screening, learning disability screening for school-age kids in primary care, but that's just an aside. DU has, that's a good place. We also have, from the learning, speech and learning at Children's, they do reading assessments, but that's not policy. That's just assessments.
This looks like it's coming from Lori. What was the name of this is actually a multi-part question. What was the name of the assessment that you are using for the pilot with advanced PCPs? And then in some school districts, BOCES, they will do the ADOS. Then the child goes in for a medical evaluation and it's too soon to do the ADOS again. Thoughts? And then also, when will you be branching out to southeastern Colorado, La Junta, Lamar, Rocky Ford?
Well, we're actually thinking about going out to Pueblo and Alamosa with some telehealth, but I don't know if that's the area. My geography isn't good, but that's southeast. So it's a STAT. It's screening, STAT, screening test for autism in toddlers and young children. That's a secondary screener. And what was the other question? What was the other part? Oh yeah, okay, I remember. Okay, so so if somebody had an ADOS done by somebody who is reliable and well trained in doing the ADOS, we don't need to repeat it. We don't need to repeat it. So I don't know if this answers your question. We don't have to repeat it. Now sometimes we will see kids where we're not certain. And so we will, we'll have kids come back again. And sometimes, 6, 12 months later, we may do it again. But we, if an ADOS was done somewhere else and it was done well, we don't need to repeat it. But if it's done at BOCES, that's not the medical diagnosis. So the pediatrician could give the medical diagnosis. I mean, we tell the residents in primary care clinic, if you think somebody has autism, we need these kids to get services, give the diagnosis, we could then get other things going. I mean, the main thing is to get services going as quickly as possible. And I think I'm getting a minute and a half. Okay, who is a burning question? Okay, or a burning comment? Have you had a chance?
I just had a really quick question about whether or not the STAT could stand in for the ADOS in conjunction with something like the ADAIR if it's something that's faster to give and therefore could be helping to reach as many people as possible.
The ADAIR takes a long time. So that's not a quickie thing. I mean, in South Carolina, what they did, there was an article that came out in Pediatrics a year or two ago. And so they had something where they could not get behavioral therapy until they had an ADOS. So what they did instead, they got money and they did a STAT. They did the STAT. They didn't give them a diagnosis of autism, but somehow they had some waiver. And then later on, they went and they did the ADOS on these kids, and there was very high correlation. It's a secondary screener. It's not a diagnostic test. I think it depends your clinical judgment. I mean, some kids you probably don't need to do anything. Yeah, and so I think it is a secondary screener, and it could be done. You certainly could do it. I don't know if you do the ADAIR and observe a kid and get a good history, maybe you don't need to do it. I don't know. Yeah. Okay. So one more, I promise.
Yeah, just related to a lot of what we've been saying. I'm Anna Cronky. I'm also with Clear Child Psychology. But thinking from a policy and private insurance perspective, I mean, I think all of us who are doing this work would agree that there needs to be, some more efficient ways to get this done, get kids referred for services. But as you mentioned in South Carolina, there's some roadblocks. But here in Colorado, there's talk that TRICARE is going to require ADOSs not just once, but every 2 years ongoing for any kind of services. Medicaid is talking about requiring an ADOS for Okay. But they're changed. Okay. Yeah, right. Not here yet. Okay. 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 I'm thinking in just in my research, in some states, they do have that. I mean, Utah, 18% of their insurance providers require the ADOS. South Carolina, there's insurance providers. I mean, is there a policy piece that we can be doing so that doesn't happen? That's a big concern for me, that what we know that's best practice maybe isn't in line with the policies or the insurance requirements.
Well, I think insurance, I can't say it on the mic, but anyway, so the thing is, there are studies going on that could potentially affect policy. That's why we're doing this multi-site study to say, what's a good clinical impression compared to the ADOS? What's the correlation? It's not the end all and be all. But I think the more we could dig down, the better. I think the sooner we get kids in, that's the most important thing. And then we could always go back to the drawing board and reevaluate. Usually autism is a lifetime diagnosis, but the literature says about 20% of the time we take the diagnosis away, give or take. So, I mean, kids need to get what they need from everybody, early intervention, the school system, whatever. And I think your point is well taken about policy and insurance, which is sometimes two different things. I mean, standard of care is getting genetic testing, and not all insurance pay for it. I think we have to stop. I'm really sorry, but you guys have been great. Thank you so much and for participating.